Welcome to The Explainer. Today, we're jumping right into the modern management of acute diverticulitis. You know, the way we approach this super common condition has been totally turned on its head by some really solid evidence, and we're going to walk through the data that shows us exactly how to get the best outcomes for our patients.
So here's the game plan. We're going to build this from the ground up, starting with diagnosis. Then we'll get into antimicrobial strategy, the new ways of thinking about both uncomplicated and complicated disease, and what to do for prevention. And at the end, we'll wrap it all up and apply this with a quick knowledge check.
All right, first things first, let's get the fundamentals down, because having a crystal clear diagnosis and a really robust way to classify severity, well, that's the foundation for every single decision we're about to talk about.
So at its very core, acute diverticulitis kicks off when these little pouches in the colon, the diverticula, get inflamed. And this is usually because of a tiny micro-perforation. Our focus today is on how we manage the whole complex cascade that comes after that.
Now, the modified Hinchey classification is our essential roadmap here. And this isn't just about giving something a label, it's prognostic. It tells us what might happen next. Knowing if a patient is a Hinchey 1A versus, say, a Hinchey 3, that completely changes our entire game plan, from just watching and waiting all the way to heading to the operating room.
So how do we actually stage a patient? Well, it all comes down to imaging. Ultrasound is a fantastic first look for uncomplicated cases. It's non-invasive, has a solid 92% sensitivity. But the CT scan, that's still our gold standard. Its sensitivity is slightly higher at 94%, and it has the critical ability to really see complications, like abscesses, and just as importantly, rule out other things that can look a lot like diverticulitis.
Okay, let's switch gears and talk about the microbiology and see how this shapes our treatment strategy. The key thing here is risk stratification. We don't just throw antibiotics at everyone, but when we do use them, we have to be targeted and effective. This table really shows that targeted approach in action. You see, for a high-risk patient who has uncomplicated disease, like someone who is immunocompromised, we'll use a 7-day course that covers the usual suspects, like E. coli and anaerobes. But for complicated disease, we escalate the strategy, adding broader gram-negative coverage. This is all empiric therapy, of course, designed to work right away while we wait for any cultures and susceptibility results to help us fine-tune the treatment.
Now this is where the modern evidence has just completely changed the game. We're about to challenge some beliefs that have been around for a long time by looking straight at the data from some major randomized trials.
You know, for decades, treatment included things like mandatory bed rest. The scientific evidence for it, well, let's just say the evidence was on a very, very restrictive diet of its own. And it's not just about bed rest. We're now reevaluating everything, including something as fundamental as the routine use of antibiotics.
This has been one of the biggest, most important questions in GI medicine over the last decade. And the answer, which comes from two huge, landmark trials, has fundamentally changed the standard of care for the vast majority of patients who get this.
So let's look at the definitive proof. You have the Scandinavian AVOD trial and the Dutch DIABOLO trial. Both ask the exact same question, randomizing patients to either just observation or to getting antibiotics. And the results? They were identical and totally unambiguous. There was no difference in complications, no difference in recurrence, and no difference in recovery time.
This number, this is the key, about 3%. The big fear was always that if we held back on antibiotics, things would go south, right? The patients would get worse. But in these massive trials, the rate of progression to complicated disease was just 2 to 4%. That single data point confirms that a selective, watch-and-wait approach is safe in the right patient.
Okay, so now we're going to escalate our discussion to complicated diverticulitis. Here, the stakes are definitely higher, the evidence is a lot more nuanced, and the decisions we make involve some really significant surgical trade-offs between short-term risks and long-term outcomes.
For purulent peritonitis, or Hinchey 3, we face a major fork in the road. Data from the big trials, DIABOLO, LADIES, and SCANDIV, show this really complex trade-off. On one hand, laparoscopic lavage, or just washing things out, leads to more short-term reinterventions and a higher chance of recurrence later. But, on the other hand, it results in way fewer patients ending up with a long-term stoma, and it's cheaper. It's a classic pay now or pay later scenario that really needs a careful, patient-centered conversation. So when a resection is unavoidable for Hinchey 3 or 4 disease, the next question is what to do with the two ends of the bowel. Historically, the Hartmann's procedure was the default. But now, randomized trials have shown us that in stable patients, doing a primary anastomosis, sewing the ends back together, is just as safe. Morbidity and mortality rates are similar. The crucial difference? It dramatically drops the risk of needing a permanent stoma, which happens in almost 40% of patients who get a Hartmann's. That's a huge deal for quality of life.
You know, managing the acute episode is really only half the battle. Once that's done, our focus has to shift to secondary prevention. How do we minimize future risk? And how do we make sure we haven't missed something more sinister hiding underneath?
The long-term strategy is all about pragmatic, evidence-based advice. So yes, lifestyle changes like losing weight and quitting smoking are recommended. A high-fiber diet is also a good idea. But what's really important is what's not recommended. Medications like rifaximin and mesalazine, they haven't actually been proven to stop it from coming back. And maybe most critically, a routine follow-up colonoscopy after a CT-proven uncomplicated episode isn't necessary. The risk of finding colorectal cancer is about 0.5%, the same as in the general population. We only do it for complicated cases or for clinically suspicious.
Okay, let's put all this knowledge to the test. I've got a couple of clinical scenarios here just to see how these evidence-based principles actually work in the real world.
All right, case number 1. This one's all about managing special patient populations. We know the general rule for uncomplicated disease, but does that rule apply to this patient?
And the answer is absolutely not. Immunocompromised patients were deliberately left out of those no antibiotic trials, and for a very good reason. With a blunted inflammatory response, their risk of perforation is just higher. This group is the key exception to the rule. They need antibiotics and very close observation.
Okay, our second case gets into elective surgery. This isn't a decision made because of an acute problem, but because of the burden of chronic or recurring disease. So, what does the evidence say we should expect?
Right. The direct trials showed us that for these patients with smoldering or recurrent disease, an elective resection brings a significant improvement in their quality of life. But that benefit comes at a price. There's a real risk of major surgical complications, including an anastomotic leak rate of around 15%. This just highlights that elective surgery is a highly preference-sensitive decision, all about balancing a better life against some pretty significant potential harms.
So we've seen just how powerful good evidence can be in completely reshaping how we do things. And it leaves us with this one last thought to chew on. The guidelines give us a great framework, but how do we move beyond them? How do we start to integrate individual patient factors, things like genomics, maybe microbiome data, to get to truly personalized risk stratification? That right there is the next frontier.